So welcome. This is Denise Noyer-Rez with AIM Wellness Clinic, and I am excited to host this teleseminar webinar with people that specialize in fertility as well. And so welcome to our Aim to Get Pregnant teleseminar webinar. My intention for you is for you to discover, get some insight about how your body is and become more informed about fertility and testing of fertility, so maybe it doesn't feel so scary, and that you can make your own decision based on where you are today, and to give you some coping mechanisms that can help support you until you do conceive. Now I get the pleasure of introducing Dr. Nurit Winkler. She is a reproductive endocrinologist and infertility specialist. She's going to be talking to you about fertility testing. And so we kind of had the little of the emotional component, and now we're going to get into the technical side. Anyways, Dr. Nurit Winkler she's double board certified in obstetrics and gynecology and reproductive endocrinology and infertility. She has a strong inner belief that nature plays an important role during infertility treatment, and she tries to integrate a more holistic approach. She believes that each patient is unique in their underlying diagnosis and response to fertility treatments. So she adjusts her protocols to meet each individual's specific needs. Dr. Winkler is skilled in many different fertility treatments, such as IVF protocols, natural frozen embryo transfer, standard IVF, mini IVF, pre-implantation genetic screening, also you may know as PGS, egg freezing, egg donation, and surrogacy. Dr. Winkler, I've had the pleasure of working with her, and I've seen her help the couple. What's so wonderful about her is not only is she brilliant and an amazing doctor, but she is so caring, and she really just takes the time to listen to your specific needs so that she can help guide you and get you to get pregnant the safest and fastest way, and also the easiest way. I've had many patients where she's just really supported them trying to get pregnant naturally. And then of course, if something else needs to be done, she's always there to support them as well. So I just really admire her. And Dr. Winkler, thank you so much for taking the time to be here today and share some of this valuable information. So without further ado, please take it away.
So good morning, everyone, and thank you for joining this panel. I just feel so great being part of this panel of specialists. And Sarah, I've just listened to your talk, and I couldn't agree more on everything you said. Going from positive reinforcement in life in general to, the stress of infertility. When they looked at, when they look at stressful in life, there is like cancer and death, and infertility is really up there. It's such a big toll on couples and singles, and the need to find support, and the need to understand that. And even more so, as you mentioned, it's very important that each treatment will be specific for the patient. So I can come out and say, you know what, statistically, you'll do better with IVF, but this is not what they feel they want to do. And I believe, like with anything in life, you should really do what you're comfortable with, and no matter. So I think the role of a fertility specialist is, of course, have all the knowledge and the expertise of sitting down and said, okay, this is what we know about what's happening. This is what I would recommend, but I want to hear from you where you are in this process. Do you want to be more natural? Can we do it? And I'll go and talk about more the technical testing of fertility, but I think that a very important concept that that Sarah mentioned is not only the emotional part, everything that happened with the couple, and I see it all the time or so frequently that especially the female and male coping mechanism and what they go through fertility are so different, and that caused so many clashes and issues that were never there before. And I usually just let them know, and of course I'm going to send them to Sarah, and I'm not going to, but to let them know this is very normal. the coping mechanism is different, the worries are different, and it's very normal to have all those clashes. And the good news, they go away after things are solved. So it's not one of those things that leave scars forever. But most importantly, it's very common. And so moving forward now, and I definitely, I want to talk a little bit about diagnosis of infertility. And I wish I could, yeah. So the first question is, when should we start worrying? Because the reality is nobody wants to go to a fertility specialist. It's almost like going to the dentist. It's like, why do I need to go there? There is also like a loss of control, especially when it comes to fertility. Like, I want to try 1 more month. So I want to see if it's going to work. So the question is, when is the real cutoff? They're like, okay, I need to go there. Next slide. So the definition of infertility, according to the ASRM, which it's a very technical one, is that infertility is, the definition is 12 months or more of appropriate timed unprotected intercourse or IUIs. I mean, this is a very complex definition, but the bottom line, couples that live together that have regular intercourse, should be able to conceive within 12 months. Now, of course, there's many exceptions for that. For example, if the couple is not having a regular intercourse, and it's not uncommon that I sit with couples in my clinic and they said, well, we have intercourse, once every 2 weeks. This is not enough. Or, we live together, but he travels a lot, or he cannot ejaculate or be in things, and you realize that they could have not gotten pregnant. Or patients, for example, that have irregular periods. So there is, for those patients, or there's no reason to wait the whole year. Other exception for that, next slide, is of course, women, how do you move the next slide? Women at age 35, we usually tell anybody at age 35 or above to basically after 6 months. And the reason why we want it to be a shorter duration, because we want to have more time to be able to diagnose and possibly treat or overcome any specific issues. Now, there are a sheer amount of couples and singles now that are coming to do fertility testing prior to conception. These are couples in their early 40s or late 30s, or even single that are about to get married. And I really see a big advantage of having fertility testing doing as early as possible. And the reason for that is that there are many fertility diagnoses that we can take care of, but can take time. So if a couple comes early enough, let's say somebody's in age 38, 39, or 40, and we discover there is a sperm issue, it gives us enough time to try and work on it, which can take 4, 5, 6 months, as opposed to just say, oh, you need IVF and ICSI. But if couples come to us and they're already in 41, 42, sometimes we don't have the time. On the same token, if we discover that the fallopian tubes are closed, the couple can have intercourse for the rest 7, 8, 9 years, and they won't be able to conceive, and that they're missing on this opportunity, or the window of opportunity of getting pregnant. So I think the big advantage of an early fertility testing is really knowledge. And as long as you do it with a fertility specialist that are honest enough, and I feel that I know many great fertility specialists in the LA area and outside that really want to help. And the purpose is not to see somebody said, you know what, everything is great with you, why don't you do IVF? I mean, this is really not. The purpose is, why don't we see, well, if there is any problem, if there is no problem, wonderful, then try and conceive naturally. If there is a problem, let's see, can you do some TCM? Can we repair it in a different way? Or vice versa. Sometimes we have women that are single or just dating or just getting married, and they want to have kids. Let's say, oh, I want to have I'm now in my 30s, but I really don't want to get pregnant until I'm like 34. And I said, let's just do some basic fertility testing, because if your ovarian reserve, the number of eggs that you have, is great, and the sperm looks good, then great, wonderful, you can keep your plan. But if you have, for example, diminished ovarian reserve, we see that your ovaries are acting older, you might have to change a little bit those plans. And I'm a big believer that you can, especially something like motherhood and become pregnant and wanting to have a child cannot dictate only by a chronological age. If somebody is not ready to be apparently shouldn't do it. But if somebody's saying, you know what, I'm ready, but I don't know if I should do it now in 2 years, and her ovaries are depleted, then I would say, you know what, maybe you should consider doing it a little bit early, or at least follow up on that. So I think that's a big advantage of early fertility testing. And those testing can be honestly done in 2 appointments. You know, we do one ultrasound and blood work and another one if needed to test the tubes, and within 2 weeks we have all the information that we need. So next slide. So I want to talk briefly about causes of infertility. Let's move to the next one. And every time when I look at how couples what's the cause of infertility, we always divide it into male and female. And it's very interesting that a lot of the time it's both of them. There is commonly a male and a female component, and each of them feel guilty about that in different ways. But men infertility, it's at least 40%, and there is definitely an increase in male infertility worldwide, especially in westernized country. Nobody knows why. There are many different theories. The other thing that is very misleading, that it could be the most handsome, young, athletic guy, and he still have a very low sperm, and vice versa. So you never know. A low sperm count does not always give signs. I feel like females infertility sometimes can cause irregular periods or other things. With male infertility, sometimes there is diminished, they have some sexual dysfunction, but a lot of the time there is no way of knowing until we do a semen analysis. So about at least 40%. And the other is the female causes, and we talked about ovarian function and tubal and so on. So talking a little bit about how we get pregnant, and every time when I look at it, it's a miracle for me that there are even babies in this world, because it looks so complex. And I remember studying it, I would think to myself, there is no way I can get pregnant. Like, if all of this need to happen every time, like, how is that even possible? Because it is in some ways very complex. But basically, if we looked at the diagram, the first one, there is ejaculation in the vaginal area. A lot of the sperm, by the way, get destroyed already during this phase, and that's why sometimes IUI, intrauterine insemination, is helpful. The sperm have to swim all the way up to the tube. Fertilization actually happens in the tube, not inside the uterus. We have ovulation of the egg captured by the tube. The formation of the embryo is inside the fallopian tube, and then implantation happens about 5 days later inside the uterus. So all those things needs to happen in order for a pregnancy to actually happen. So next slide. So with male infertility, the sperm is produced by the testicles, stored in the epididymis, and then produced outside through the vas deferens and through ejaculation. Next slide. So the next slide. Can we get to it? So when we do fertility testing, what we like to see is testing the ovaries, tubes, uterus, sperm, and I leave others. So let's move to testing the ovaries. What things we need to know about the ovaries? In the next slide, we have 2 main things that we want to know. One, are women ovulating? And it's something that a lot of women that have infertility are very concerned, because there is so much reading about luteal phase defect and is your progesterone is good enough. But the reality is women have regular periods, they do ovulate. And I don't see really the reason to check the progesterone level, although some women really wants to check it, and it's fine. But the reality, if women have regular periods, they ovulate every month. Otherwise, they would not get regular periods. So the first thing to know whether you ovulate or not, are your periods regular? And regular, it's between, 25 to 34 days. So even if the periods don't come exactly the same time, if they're a couple of days apart, it's still okay. So one thing is like, are your periods regular? The second, and it's a very, very distinctive cervical mucus, that some women are very conscious of it or aware of it, and some are not. The cervical mucus, usually, it's one of the most reliable signs of a natural ovulation or almost ovulation. So the cervical mucus is basically the peak estrogen level that happened just before ovulation. And it's equivalent to a positive ovulation kit. In fact, I tell women, you know what? if you know when your cervical mucus is different, you can test for yourself an ovulation kit just to know it's true, but this is the most reliable factor of pre-ovulation. Then I recommend for patients to have intercourse that day and the next day, because ovulation will happen within 24 hours, 48 the most. But not all women get the cervical mucus, not all women can say. But for those lucky ones that do, you honestly don't even need to check ovulation kit, because the cervical mucus, the distinctive one, the very sticky and different one that happens around day 14 mid-cycle, is the one that indicates that ovulation is about to happen. The third one is the ovulation kit, and actually ovulation kit is not a bad way to, or it's actually, I find it an effective way to try and improve your natural fertility. So the ovulation kit, what it does, it detects the LH surge that happens a day or two before the natural ovulation. There are many kits out there. The advantage and disadvantages of the kit. The advantages is that it helps you know when is the most fertile days of that month. And especially going back to Sarah's kind of lecture about this time intercourse, it gets very tired for couples that are trying to conceive to have intercourse every other day. It's tiring, it's not fun, it's exhausting on multiple levels. And be able, although it's not very sexy and natural, saying, instead of us having intercourse every other day, which at that point the couple knows that they're doing it for that, let's have intercourse when we feel like, but also there's going to be these 1 or 2 days that are the most important one, and we trigger the intercourse for that time. The disadvantage of the ovulation kit, that it can drive women and couple crazy, because those ovulation kits are not easy to interpret. Some of them will tell you that you're supposed to get 1 line when there is no ovulation and 2 lines when there is ovulation. But it tells you that the second line needs to be darker or the same as the first line. It drives people crazy, because it's like, I don't know, like I can tell, is it darker, not darker, is it darker, not darker? I always tell my patient, don't worry, send me a picture on my iPhone, don't put your name, so it's going to HIPAA compliant. I'll tell you, but the reality, if there are 2 lines, you're fine. And then there are other kits that are even more complex, and they have like flashy light and shiny light, and the more complex they make it, the more anxiety provoking they are. So I think one of the downsides of the ovulation kit, that are not always easy to interpret, and that's where the fertility specialist will help you with that. Myself, and I'm sure that others will tell you, just call me, send me a text, call the office, we'll let you know. Actually, texting is not good, but email me. The other things that there is some false, those ovulation kits don't work for all women. There are a certain percent of women that the ovulation kit don't work for them. They either show all the time negative, or they either show all the time positive. It can be very misleading. For those women, one way that we can detect ovulation is following by ultrasound. It's a little bit of an expensive way sometimes to do that, and not very easy, because you need to come to the office more frequently, but we can actually look at that follicle and then follow up, see when ovulation is going to happen, and follow up and ovulation actually happens. So a little bit of a more complicated way to do it, but it can absolutely be done. So ovulation, that's the first thing we need to know. And as far as fertility testing, I tell my patients, from my point of view, if you're having regular periods, you're ovulating, and I can, of course, help them determine when is your natural ovulation occurring, and find a way for them to know that. Next slide. The second thing that we want to know about the ovaries, other than their functional, meaning are they hormonally, ovulating every month, it's what we call ovarian reserve testing, meaning how many eggs the ovaries have, compare also to the chronological age. And as you know, there is, women lose eggs actually from birth until menopause, basically every month. And it's of course when we are younger, we assume that the quantity of eggs is great, but the reality is that the ovarian age does not always reflect the chronological age, and could be younger women that the ovaries are just aging quicker. So there are different tests that can give us an estimation of the quantity of the eggs, and sometimes quality. So there are a couple of tests. One of them is an ultrasound, the second are blood work. So the ultrasound, we do something called antral follicle count. And basically, the antral follicle count are the group of eggs that started to grow that month, and it's a reflection of the total amount of eggs that women have. For example, if you look at the ovary in this picture, you can see these little round circles, and those reflect those follicles. Women in their 20s might have 20 follicles between the two ovaries. Women in their 30s may have about, let's say, 12 follicles. Women in their 40s might have 8 follicles. So if I do an ultrasound on the second or third day in somebody who's 30 or 35, and I see about 10 or 12 follicles, it looks great. I already feel great about it. I said, you know what, we can do some blood work, but your ovarian reserve overall looks very adequate and good for your age. On the other hand, if I scan somebody in age 30, 35, and I see only 2 or 3 follicles, that indicates that their ovaries are acting older. That does not mean that she cannot get pregnant. And this is very important when we interpret all these. None of them are like doom, like this is it, you're not going to get pregnant, you're always like you're 45, you need to do echinacea. None of them is right. It only means that we need to understand why maybe the couple is not getting pregnant, how efficient we need to be with fertility treatment, what protocols we need to do, and keep working on it. And that's very important, not to take those tests as a kind of, okay, this is not going to happen for me. So antral follicle count, it's a very sensitive way of assessing ovarian reserve. The second one is a combination of blood work that we do on the second or third day of the period. One of them we can do at any time of the period, and it's a combination like a hormone called FSH, estradiol, and AMH. Of those 3, I have to say that the AMH, anti-Mullerian hormone, is one of the most sensitive tests to detect ovarian reserve. The advantage of the AMH, it can be done at any time of the cycle. So patient can come in at any point of the cycle. We can draw the blood work and know. And we want the AMH, of course, there are different criteria, what's the number, but it gives us a very good indication of the ovarian reserve, as opposed to the FSH and estradiol, that are hormones that change from one month to another. One more important concept is that the ovarian reserve testing need to be interpreted as a group, meaning if somebody has, I do a scanning and somebody has 6, 7 antral follicle, have about 10 antral follicle, and her AMH is a little bit on the low side, that's, 1 second. Amber, I can't, I'm giving a seminar. I cannot talk to anyone. One. I'm so sorry, it's clinical work, but if we basically, let's say I'm scanning somebody and she has about 10 antral follicle and the AMH is slightly on the low side, I interpret it one way as opposed to if I scan somebody and she has a low antral follicle and also a low FSH and estradiol. So the interpretation of those blood work need to be taken in a group and not as a single test. There is also a company that I use, Reprosource. There are others that specialize in ovarian reserve, and we send them the blood work, and they actually give us a full report that include hormonal testing for like FSH, estradiol, AMH, and something they call egg retrieval score, which is like if we were to do any treatment such as IVF, how many eggs we get. Now, we don't really need those numbers as far as egg, but it's another indication of how's the fertility of that particular woman compared to her age. So that's the kind of ovarian reserve testing. Next slide. So again, from the ovary point of view, what we need to know is ovulation, not ovulation, and we talked about it. The ovarian reserve testing, that's the antral follicle count, and the hormonal testing. The second is the tubes, and the fallopian tubes and uterus. So uterine factor as infertility are pretty rare, but they can be, but they're not as common. But closed fallopian tubes, for different reasons, they're not that uncommon. And the other problem with that is that there is sometimes some misconception that if the fallopian tubes are closed, it will give any signs. the reality is that it doesn't. You know, I would say that 99% of women that have a closed fallopian tubes or blocked tubes will not give them any signs. It doesn't cause irregular periods. It doesn't cause any pain. The only way we would know it is by doing a test. The test, one of them to look at the fallopian tube, the hysterosalpingogram, it's a test that it's done either at a fertility center or radiology. The radiologist, so the fertility specialist, inject a small amount of radiographic dye that looked into the shape and the shape of the uterus and whether the fallopian tubes are open or closed. And we can get a couple of results. One, the tubes are open and the uterine cavity is perfect, wonderful. The HSG test by itself can increase pregnancy rate for 1 and 2 months. The second result was, you know what, the uterus was perfect, but the fallopian tubes were initially closed with mucus plug, and the HSG test was able to open it. Then great, then we kind of solved the problem. The third one will be 1 or 2 fallopian tubes are blocked. And if 1 fallopian tube is blocked, it's good for us to know, but the patient can still get pregnant naturally. If both of them are blocked, we know that no matter what we do, we probably have to move to IVF. Next slide. So other ways to test the uterus other than the tubes are tests such as ultrasound, that we can look at the endometrial lining, serum infusion hysterography, and so on. So I'm not going to get into that, but there are different imaging testing that can be done other than the HSG. I think that the big advantage of the hysterosalpingogram that it's one test that look at both. Next slide. These kind of are imaging, but I don't have a pointer. Can they see my pointer? Not so much. They just show all kind of anomalies within the uterus that can be detected by an HSG, such as scar tissue and polyps, but you know, we'll move to the next slide. Yeah, let's move to the next slide. And this is another test that we do on patients that we are concerned that, for example, we have to do IVF and we at that point don't need much information on the tube. It's an easier test that can be done in the office. It's called saline infusion hysterography. It's a very sensitive test to look at any kind of anomalies within the uterus, polyps, fibroids. And if you can see, the first test look at a completely normal cavity. I cannot see my slide, my pointer, and the other ones look at anomalies within the uterus. Yeah, next slide. Finally, hysteroscopy, and I think there's some centers that really like to do hysteroscopy as a fertility testing. Hysteroscopy is a surgical procedure. I personally don't think that we should put anybody through a surgical procedure unless there is a clear indication. But you know, it is indicated when we see polyps or fibroids or things that we think will affect implantation, and it's, you know, a procedure that I personally do only if there is a clear indication for that. But you know, those are imaging of a hysteroscopy. It's an in and out procedure. There's no cutting. We go in with a camera. If there is a polyp, we remove it. It's overall a very easy procedure. But with anything, I think that it's easy if it's not done on you. So I think that I try to avoid any surgical procedure unless I really think there is something that I can correct. Next slide. Finally, testing sperm. And, you know, it's interesting. There is, I feel like females are more more, you know, when we have to test fertility, one of the difficulty we sometimes find is actually testing the sperm. One of the biggest worries men have is really that there is something wrong with the sperm. It's almost like it's okay if the female partner have any kind of fertility issue, they can cope with that well, but the biggest concern is, what if my sperm is low? And sometimes even getting the male partner to do that is not the easy task. Now, a couple of misconceptions about testing the sperm. Testing the sperm, it's a simple semen analysis. The men have to abstinence between 2 to 4 days, and the reality is that the longer the abstinence, the lower the quality of the sperm. So there is some men that think, oh, I'm going to have a semen analysis. Why don't I accumulate sperm now for 6 days? That one, it will show that I have a lot. In reality, the quality will go down. So we always tell the man, and I know it's go back to Sarah's kind of lecture about, telling patient what to do, but short ejaculate, short abstinence, 2 to 4 days the most. The sperm look at different parameters. We look at the volume, at the concentration, motility, shape of the sperm, and so on. What's very important to know about testing the sperm is that one test is not enough. So if it's a low sperm, it's always good to repeat that. Despite what a lot of, you hear it at many places, oh, if the sperm is low, we just have to do IVF, we just have to do ICSI. This is incorrect. I think that male infertility needs to be treated the same way that female infertility. We need to try to understand why the sperm is low. We need to try to correct it. For example, Denise will be able to talk more about it, but TCM could be very helpful for that. Antioxidants could be very helpful for that. And in my view, we should try and improve the sperm the best we can before moving to IVF and ICSI, unless, of course, the patient's age is at an age in which we don't have the time to do that, because it can take 3 to 6 months before we can improve sperm. One more thing to mention about testing sperm is that there are newer tests now that we're using that looked more into the quality of the sperm. So there are many couples that maybe have unexplained infertility that underwent regular tests, and the sperm looks completely normal, to then just discover, actually, we are doing this new test and realize there is other problems that we were not aware before, so it's not so much unexplained. So testing sperm is very, very important. It's a very easy test. We can get the result within 24 hours. Highly recommended. Next one. So finally, my take-home message. I think that infertility is not the easiest journey, but it is a journey. And it's not like many journeys in life. It's not necessarily one that we wanted to have, but that's kind of part of it. Is what it is. I think that getting a lot of support and help from specialists such as Sarah's support group, meeting with fertility specialists as soon as possible, just to have an idea of what's going on, and just having, everything is okay, keep trying, or why don't we improve or continue TCM, can be very, very helpful. And also very important, always, work with fertility specialists that kind of accept your view of things, and you have to feel comfortable with treatment. Open to questions. I don't know if we have time now, or there is my email and my contact info and so on.
Hi, Nurit. Dr. Winkler, thank you so much for that. Great information. We don't actually have time for any questions now, but we'll make sure that we put your email, and we'll send out your email to anybody who needs to get a hold of you, who has a question. Is that okay?
Yeah, absolutely.
Okay. Thank you so much for all that. I hope you have a great day.
Thanks.